Hello and welcome to our broadcast. I'm your host, Syl Trepanier, Senior Vice President and System Chief Nursing Officer at Providence. As a reminder, the information provided during this event is for information purposes only. So if you have any medical questions, please reach out to your primary care or healthcare professional. Joining me today during this live event is Heidi Dishneau, an advanced practice registered nurse from Seattle, Washington. Hi, Heidi. How are
Good,
you?
good morning. I'm good, thanks. Thanks so much for inviting me.
Oh, thanks for joining us. It's been a long time in the making. We tried to get together and we had a few hiccups, but here we are, and I'm really glad that we're able to do that. Let's get us started. Heidi, tell us a little bit about yourself and what you do.
Sure. So I'm an oncology certified nurse practitioner. I'm board certified in family practice, but I have a advanced certification in oncology and have spent my whole career in oncology. So that's the space that I know. I started off taking care of people with the hematologic malignancies, leukemia and lymphoma, and in the little niche of bone marrow and stem cell transplants. But for the past, 13, 14 years or so, I've been taking care of people with breast cancer. I always kind of define it as sort of the bookends of breast cancer because I see them from the pre-vivor phase. So, people who are at high risk for breast cancer, whether they have a genetic mutation or other factors that put them at high risk, a little bit of the perioperative, so before surgery, after surgery care, and then through the survivorship phase. And so my primary practice is based in clinic, even though I'm embedded within a surgical practice.
Dang, I have so many questions just with what you shared here, but I'm gonna wind back the clock, and before we talk about your practice today and how you got there, take us back to Heidi chose to become a nurse. Why was that?
So part of it is I believe I always tell people I come from a family of nurses and teachers for several generations. And so we're the helpers, right? I think it was just sort of part of my identity and part of who we are as a family. I've always loved science, and I knew that I wanted to have some type of career in healthcare. This will date me terribly, but I was one of the candy stripers in high school, volunteering in a hospital. So I used to wear the little red and white striped little aprons or whatever that we did to deliver flowers. So um, I intentionally chose nursing because the whole foundation of nursing practice is based on the care of the whole person. And that really aligns with my own personal values for connection. I am always aware that my patients are so much more than their diagnosis. And to be able to see them for who they are and walk with them through this journey, that's probably one of the hardest times in their life, makes the job so much more meaningful to me. And it's something that makes me proud to be a nurse because I think that this is what we're trained to do.
Yeah, thanks for that. I can relate to that and so many other nurses. I'm hearing. So it came from your upbringing, but also at the same time recognizing you wanted to do something in healthcare. This particular profession was very much aligned with your values at the time,
Yeah.
and it sounds like it still is.
Yeah, and I think, I often think there's certain professions, and nursing is certainly not the only one, but there are many professions where what we do is a significant part of our identity, right? I mean,
Mhm.
it's I don't just come to work to do a job, I'm a nurse. I am an advanced practice nurse. It's something I'm proud of, but it's something that just naturally aligns with who I am at my core. And I see that in so many of my colleagues that I work with. And I think that that's something that, you know, um, probably most of us who went into nursing would have a similar response.
Yeah, yeah. I as I hear you describe your your journey and what drove you to this, I'm thinking about all the lives that you have touched, people who invited you in, um, and let's face it, they might invite you in, but not all interactions are created equal. And there's always a moment in one's career that just like sticks with us. They're like clinical experiences. There's a few that will never leave me, that always sticks with me. I'm wondering, what's that moment for you that that keeps on, that's sticking in your memory?
Hmm. Well, as you know, that's a really hard question, especially to ask a nurse, because it's almost impossible to just pick one. I think that working in oncology, I think most of those moments are very bittersweet. And, we all want to know that what we're doing is meaningful. And I think that for me, being in the journey with patients experiencing cancer, it's always my hope that I would help them feel less alone in that journey.
Mhm.
I've been told on multiple occasions in different ways that I'm really good at delivering bad news. And I think that's a compliment. But it's definitely, I think the first patient who comes to mind or first scenario is a 27-year-old. This was probably almost 15 years ago, who had advanced lymphoma and transplant was failing, and delivering some hard news in clinic about, imaging studies that showed significant progression of disease, and it was time to um, pivot in our treatment plan. And I will never forget this young woman looking up at me, and the first question out of her mouth in response to some of this information was, how am I supposed to tell my 2-year-old son that mommy's
Mm,
dying?
mm,
And in that moment, all I could say was, I don't know. And we both started crying. And, we're in the business of taking care of people, and we're human, we're taking care of humans, and it's a tremendous privilege. And to be able to be human in those moments, I think, is some of the most meaningful work that we can do. I ran into another patient just recently who was a woman, a breast cancer survivor that I had taken care of a couple of years ago, and I hadn't seen her in the interim. And I actually always hope patients in some ways forget about me, because then I think maybe they'll put that cancer experience behind them, and they've moved on with their life, and it's actually a good thing, maybe, if that isn't the most present thing in their minds. And she said to me, she said, Heidi, I'll never forget that you were the first person who called me to give me my diagnosis, which I thought, oh, great. What did I say? You just wonder, I
mm.
wish that wasn't what you remembered me for. But she said, I'll never forget what you said. The patient had asked me, why did this happen to me? And evidently I had told her that this isn't your fault. Um, and she told me, she said, that gave me a lot of peace. So, it reminds me of Maya Angelou's words that people will never remember what you said, people will never remember what you did, but people will never forget how you made them feel. And I think that very much guides my practice and just, who I want to be.
We are humans taking care of humans. I I appreciate how you camped that, and a reminder for us, as no matter what we do, I mean, clearly for nurses, it's important. I kind of want to suspect that it's for anything that, showing up with vulnerability
Mhm.
in the right place at the right time helps develop that trust that's required for anything to happen.
Absolutely. I agree. I think it's one of the most important elements in care. So much is there's so many amazing technology advances and things that often remove the human component from a process or a situation. And sometimes that, there's a lot of benefit to that, but we can't ever completely remove or forget about the fact that we are humans, and we're taking care of humans, and to show up as in those human moments and recognize those, I think, is some of the most meaningful work that we can do.
Yeah. I mean, you're considered an expert in your area of specialty, and so tell us a little bit more about what's your day to day. What is the professional life of a nurse practitioner that specializes in breast cancer? What does that look like every day? So if I'm a nurse out there and I'm considering it, what would you say your a typical day looks like? And don't tell me they're not all the same.
Well, you already know that, right?
I already know
Um,
that.
I love it's I have a I feel like a very narrow niche in oncology, and I love my little corner of the world, if you will. I think because I get to do a lot of variety, and I get to do a lot of listening to people's stories. So I see a lot of patients who are at high risk for breast cancer, predominantly because of family history. Some with personal biopsy results that are not cancerous but higher risk, and so I follow them. But form I get to perform a risk assessment on them to be able to educate them about what their risk is and to present options for risk management. And there's a lot of there's a partnership between me and the patient where we get to decide what does she want to do. And I'm here to support that. I'm here to provide the information, and then come up with a treatment plan or a screening plan moving forward that meets both of our goals. And I do genetic counseling. So if somebody has a family history that's suggestive of some type of hereditary predisposition, I can do the genetic counseling component and we test for the hereditary cancer mutations. So we do that testing in the office, and so I can interpret those results and present them again with recommendations based on those results afterwards. I do a lot of education around breast imaging with patients. So, we review their images in the office. We talk about what the results actually mean. Some of it's translating into, normal language. I have the real distinct pleasure and honor to be very strong partners with our breast radiology team. And so I talk to the radiologists multiple times a day. And it's nice to be able to pick up a phone and say, hey, I'm seeing this patient right now. I have a question about this imaging. What did you mean by this? And then they can kind of tell me what they were thinking, and to be able to walk into a patient's room and say, yeah, I was reviewing your imaging with the radiologist, and here's what we're thinking. Here's what we are recommending. It goes a long ways towards, again, bringing that human connection into the room and offering reassurance and building trust. I also see a lot of post-operative patients, so women after their surgery, and that's always unique time because I think there's a tremendous sense of relief for many women to have that piece of it behind. For many
Mhm.
patients, that's sort of a milestone of my cancer's gone, because it's been surgically removed. So there's sort of this kind of emotional response, I think, in a way to that. And then I see patients for ongoing surveillance after their breast cancer treatment. So we see them every 6 months, usually for the first 5 years, and then follow them annually after that. Those are always kind of fun check-ins too, because, you get to, I always think of it like a butterfly. You see that there's a metamorphosis from, I'm there at the beginning of the diagnosis, and then I watch this metamorphosis process that is really quite beautiful in so many different ways in women. And then I also get to see breast cancer survivorship patients. And so that's a whole unique kind of arena where we talk about a lot of things that are happening because of their cancer history that may not be directly impacted by their treatment, but they're living with symptoms or things that they need to have addressed that don't always have time to be addressed in other ways. So it's definitely a broad spectrum within a very small corner of the world in oncology.
Yeah. Thank you. Thanks so much for offering us these insights. We get quite a few questions about breast cancer, so let's go a little bit deeper and more clinical, if you will. So what are the most common signs of breast cancer?
So obviously, a new lump in the breast or even the armpit area needs to be evaluated. Any type of thickening or swelling or kind of even like a texture change in the breast is something that should be evaluated. Skin irritation, flakiness, or almost like a rash or something around the nipple and the areola also needs to be evaluated. And any spontaneous nipple discharge, particularly if it's happening in just one breast, that is anything other than like especially if it's clear or bloody, we always want to have that evaluated. All of those things can mean a whole lot of different things besides breast cancer, but any new symptom warrants evaluation by your provider and should be brought to somebody's attention, and additional imaging and investigation needs to be done to make sure that it's not a breast cancer. I think it is important to note that most breast cancers are diagnosed on screening mammograms long before women can feel them in their breasts, or even before we as clinicians can identify them on clinical exam. So it is really important to get that screening imaging.
How about for guys?
Very, very similar. And that's, the male breast cancer rate is it's about 0.7%, I believe, something very, very rare. Certainly men who have family histories of breast cancer may want to be a little more aware that men do have glandular breast tissue. And so anytime that there is either a lump, particularly around the nipple and the areola, because for the vast majority will predominantly show up in that central chest area. But any nipple changes and sores that won't heal, I think, always warrants a little more investigation. And we always counsel, partners of our patients and, any men that we interact with, that, don't let anybody just dismiss you because you're a man and men don't get breast cancer. I think, we often, the men that we do treat in our practice with breast cancer, that's often been the story is, that somebody has dismissed for a number of years because you're a man. And so, when men do present with concerns, we will arrange breast imaging, and they can do, a mammogram, and they can do an ultrasound for investigation.
Yeah, and I'm assuming that that's not good, for either sex. But yeah, if it's not caught on in early stages, there's some significant ramification for that.
Yes, we much prefer to diagnose breast cancer at earlier stages because it generally requires less treatment. It's better outcomes for the patients for sure.
So if I'm someone that's looking for an expert like you, how do I find experts like you?
We are often hidden in all sorts of different arenas within the breast health world. So, most organizations that have big cancer centers like the Providence Cancer Center, our Cancer Institute here at Swedish, will have within breast, usually it's within a breast surgical practice. And so we'll have nurse practitioners who work with our high risk breast cancer program. The other place where some of our locations offer these type of services is in affiliation with the actual breast imaging center. Sometimes that makes a little more sense. So I always encourage patients to connect with your primary care providers, and most of them will know that where to refer to for breast specialty care. If you don't get anywhere there, check with the radiology teams that are doing your screening mammograms. They will certainly know who in your region is someone to be referred to for this type of care.
We hear a lot about breast density right now. Can you just tell us a little bit more about why is this important for, particularly for some patients?
Yes, it's a very hot topic right now. And so many states in the country actually have laws that require the breast imagers to notify women of their breast density on their screening mammogram reports. So this is not something that is technically very new, but some of the laws have been relatively new, and therefore the language in the reports may have changed over the years. So our breasts are made out of fibroglandular tissue that is composed of the lobes, or the milk producing parts of the breast, and the ducts that express milk through the nipple, kind of some of that connective tissue that holds all that together, and then fatty tissue. And so when we're talking about breast density, we're specifically talking about that ratio of that fibroglandular tissue to the fatty tissue in the breast as it's seen on mammogram imaging. So this is purely an X-ray radiology assessment of what is that fat to glandular tissue ratio. About 50% of women have what we consider dense breasts, with only about 10% in the most upper extreme. We actually call that extremely dense breast tissue. So it's kind of the outliers are in that 10%. And there is always the concern that with denser breasts, that it may be a little bit harder to see cancers on screening imaging. And I emphasize may because that's not always the case. And I think, but there's a lot of fear about that mammograms aren't doing a good job. 3D mammograms have been a significant technological advance in our ability to effectively screen women with dense breasts. So for the vast majority of women with dense breasts, 3D or tomosynthesis mammogram is doing a fantastic job. And most centers around nowadays have 3D imaging available. It used to be, as 10 years ago or a little bit more, that not everybody had transitioned to 3D imaging. So for women who have family histories of breast cancer, extremely dense breasts, we may think about additional imaging modalities such as breast MRI or breast ultrasound, but it is important to have that conversation with your primary care physician, the breast radiologist, your high-risk breast team, to look at your own personal imaging and be able to assess, is this something where you need something additional, or is 3D doing a fantastic job?
Awesome. Thank you. Thanks for that. You talked about this earlier when you were doing your consultation, you referred to family history and you referred to genetics, and the likes. And how much does family history can add or at least influence the risk of breast cancer?
That's a great question. Surprisingly, only about 7 to 10% of all breast cancer is hereditary. So genetic mutations for breast cancer are really quite rare. That said, there's always those families that have a strong family history of breast cancer and they all test negative for a genetic mutation. We do think that family history, particularly if a woman has a first degree relative, so either a mother or a sister, we don't know exactly how impactful it is if a father or a brother were to have breast cancer. Certainly plays a role, but we know that breast cancer in a mother or a sister probably doubles a woman's risk. So the average woman has about a 12.5, 13% lifetime risk for breast cancer. So family history, especially close family history, probably we would assume that there is a risk slightly greater than at least 20%, which is our threshold for high risk screening. And it always warrants conversations with your providers to determine the best treatment plan, because for women with family history, sometimes we might want to consider genetic testing to rule out a hereditary cancer mutation. And sometimes we already know that there's nothing in the family, but there's this strong family history, and we want to watch women a little bit more closely.
Awesome. Thank
I
you.
should add too that we care about the father side of the family history. So a lot of times there's this, the urban legends or urban myths that we only care about mom's side of the family, and we very much care about the paternal side of the family when it comes to hereditary cancer patterns.
What resources do people have out there if they want to learn more about oncology?
I always encourage patients to stick to the academic medical centers, breastcancer.org, some of the more accredited scientific sites.
You mean a Google Dr. Google might not be as helpful?
Dr. Google and your Facebook friends are probably
Yeah.
not, I think we always remind our patients that every cancer experience is quite unique too. So just because we all will know people who have had different cancer experiences, and sometimes it can be very hard to put that aside and focus on your own individual experience. So I think people have the best of intentions. Everybody, wants to be helpful, wants to share their experience. But when it comes to learning, accurate medical information, it's better to stick to more of the scientific sites.
Thanks. Heidi, thank you so much for joining us today. I really
You're
appreciate
welcome.
the time that we've spent together. And thank you to everyone for listening in and sending in your questions. So, to learn more about our initiatives, our programs, our services, our ways to give, or if you're looking for help or medical advice, please visit providence.org. Make sure to follow us on social media at Providence on Twitter and at Providence Health System on LinkedIn, Facebook, and Instagram. Have a great day, everyone. Thanks for joining.